Patient admitted to UMHS on 11/21/2012 is a 47-year-old African-American male presenting with severe left lower quadrant and left upper quadrant abdominal pain and nausea. Blood pressure upon admission was 146/93. Temperature 36.4 degrees Celsius taken orally. Heart rate 115. Respirations 20. Oxygen saturation 95% on room air. Pain score 10 out of 10. Patient states approximately 7 days ago he began having mild symptoms consistent with his chronic pancreatitis, including radiating upper abdominal and back pain. Patient states eating anything besides yogurt caused a 10 out of 10 abdominal pain and has been constant for the past 4 days. Pain has improved to 6 out of 10 since receiving morphine from the emergency department. Patient denies vomiting but states there was significant dry heaving and nausea that has since been controlled with antiemetics. Past medical history includes chronic pancreatitis, alcohol dependency, type 2 diabetes and related peripheral neuropathy, hepatitis C, deep venous thrombosis of the left lower extremity, hypertension, hypertriglyceridemia, and is a 50-pack-year smoker. His immunizations are up to date. He has no known drug allergies. Past surgical history includes carpal tunnel release in 1995. Patient is currently on citalopram 20 mg per oral daily for depression, gabapentin 300 mg per oral twice daily for peripheral neuropathy, as well as several insulin medications related to diabetes. He's on lovastatin 50 mg per oral before bed for hypertension, and on several prophylactic medications for previous deep venous thrombosis. Currently, patient is on hydrocodone acetaminophen 7.5 to 750 mg per oral every 6 hours PRN for pain. Patient has history of heavy alcohol use, reporting drinking about 10 12-ounce beers per day. Currently, no signs of withdrawal. Patient is a 50-pack-year smoker and reports using marijuana occasionally, but denies use of other illicit substances. Patient lives with his girlfriend and is currently unemployed. His father is deceased from complications of type 2 diabetes and had a history of alcohol abuse. His mother is currently living and has a history of heart disease. His brothers both have type 2 diabetes. Review of Systems 1, Abdominal. Patient states abdominal pain increases with eating or walking and describes pain as sharp, burning, and constant. Patient states abdomen is diffusely tender, radiating to the back, with greatest tenderness on his left side. He states symptoms are similar to his previous attacks on pancreatitis. Patient feels nauseous but denies vomiting. His last bowel movement was non-bloody and occurred yesterday morning. Patient denies weight loss over the past week, but has not weighed himself during this time. Also denies fever and chills as well as heartburn. Patient is visibly guarding. Abdomen is rounded and distended. The color of the abdomen is normal for race. No scars or lesions present. Patient tested positive for rebound tenderness. Active bowel sounds present. No surface motion or abdominal bruits detected. Patient refused deep palpation due to extreme pain. System 2, Peripheral Vascular. Patient states that he does not exercise except when he walks his girlfriend's dog 3 times per week. Patient denies pain with walking. He claims to have a lot of stress in his life with his health complications and inability to find a job. Admits to numbness in the left lower extremity and states that feet sometimes become red when they are dangling for a long period of time. Patient denies tenderness of legs. No discoloration noted of lower extremities at this time. No ulcers present. Patient tested negative for Omenn sign and has even hair distribution. No varicosities noted. Toenails thickened. Left posterior tibial and dorsalis pedis pulse rated +1 diminished. All other pulses rated +3 normal. Left lower extremity capillary refill was greater than 3 seconds. All other extremities less than 3 seconds. Other pertinent systems to be examined in this patient would include a cardiovascular assessment. patient's history of smoking, alcohol use, hypertension, hypertriglyceridemia, and diabetes, as well as family history of heart disease, are all factors that affect the proper functioning of the heart. In addition to hypertension forcing the heart to work harder, a 2012 study on the relationship between type 2 diabetes and heart function suggested that type 2 diabetes is associated with a significant increase in the risk of atrial fibrillation. Another pertinent system to be evaluated in the patient is a respiratory assessment. The patient puts himself at risk for lung cancer and infection with a 50-pack-year history of smoking, and a 2012 study of the relationship between lung function and type 2 diabetes suggests that people with diabetes are more likely to have a decreased forced expiratory volume as well as a decreased vital capacity, thus risking impaired gas exchange.